Hi, my name is Reshma Vilnaseri. Today I will be discussing the World Health Organization and their initiative against tackling the global rise of diabetes. The World Health Organization, also known as WHO, was founded on April 7, 1948. This day, April 7th, is also known as World Health Day. Their mission statement is to promote health, keep the world safe, and serve the vulnerable. Their goals include to promote health from prenatal to elderly, to lead global efforts to expand universal healthcare coverage, and to direct and coordinate the world's response to health emergencies. The World Health Organization consists of 194 members. These members elect a leader known as the Director General. The current presiding Director General is Dr. Tedros Adhanom Ghebreyesus. A little background on Dr. Tedros. He received his Bachelor's of Science from Eritrea, his Master's of Immunology of Infectious Disease from the University of London, and his PhD in Community Health at the University of Nottingham. He served as the Minister of Health and Foreign Affairs of Ethiopia from 2005 to 2012. Under his leadership, his accomplishments include reducing the maternal child mortality rate by 60% compared to the year 2000. He led a reform on Ethiopia's healthcare system and laid a foundation for the universal healthcare system. He also expanded the healthcare workforce. His primary health extension program deployed 40,000 female healthcare workers throughout the country, helping to provide primary healthcare to rural areas. The World Health Organization is a nonprofit organization who receives funding in two different ways. The first is the assessed contributions, which are essentially country membership dues, which is a certain percentage of the gross domestic product of that country. This amount is reassessed every 2 years at the World Health Assembly. This amount comprises 20% of the total budget of WHO. The second method is through voluntary contributions, which are essentially donations. These can come from member states, other United Nations organizations, intergovernmental organizations, philanthropic foundations, and the private sector. The World Health Organization introduced the Global Diabetes Compact on the 100-year anniversary of the discovery of human insulin. The launch occurred on April 14, 2021, at the Global Diabetes Summit, co-hosted by WHO and the Government of Canada. The initiative was created to address the global rise of diabetes. There are 6% affected worldwide, which is over 420 million people. The United Nations Sustainable Development Goal Target 3.4 strives to reduce the premature mortality of non-communicable diseases by 1/3. And while many of these diseases are decreasing, diabetes has increased by 5% from the years 2000 to 2016. The initiative strives to decrease diabetes risk, especially in those deemed high-risk persons, and to ensure equitable, affordable, and quality treatment for all. Type 1 diabetes is of unknown prevention and cause. Type 2 diabetes, however, disproportionately affects those who are Black, Asian, Hispanic, or of indigenous populations. It also disproportionately affects those with low socioeconomic status and those in developing countries. There are 8 key asks identified for the Global Diabetes Compact. These requests are aimed at anyone affected by diabetes. This includes stakeholders, United Nations agencies, medical or technical suppliers, academia, and patients affected by diabetes. The first ask is Unite, which requests the collaboration of stakeholders and patients. The second is Integrate, to integrate primary care and universal health care. The third is Track, which asks to set and meet global targets. It also asks to set a global price tag on insulin, medications, and diabetes care. The fourth ask is Treat. It asks to improve access to diagnosis and treatment, especially in low and middle income countries. The fifth ask is innovate. It asks to development and evaluate low-cost technology and digital solutions for diabetic care. The sixth ask is funding, to provide affordable diabetes care, especially in emergencies. The seventh ask is to educate, to improve health literacy and education, especially at the community level. The final ask is to power ahead. The outcomes of non-communicable diseases were negatively affected by the pandemic. The compact asks that we strive for numbers even better than pre-pandemic levels. An article written by Frolic and authors in 2022 highlights the current state of affairs of diabetes and diabetes care worldwide and influences of the Global Diabetes Compact. In sub-Saharan Africa, only 2 out of 13 countries met the WHO's Global Action Plan target of having at least 80% of essential medications available for non-communicable diseases, which includes insulin. In Mozambique, children with type 1 diabetes have a dreadful life expectancy. In urban areas, it's less than 4 years, and in rural areas, it's less than 1 year. And this is due to the high insulin costs. The lack of access to affordable medication or adequate primary health care is a huge reason for these negative outcomes. The primary health care that is available often lacks the knowledge and expertise to manage the complex disease of diabetes. In India, 74 million people have diabetes. Accessibility due to location is typically not an issue unless you live in the mountainous regions. Affordability due to the economic divide is often what affects the accessibility. Those who live below the poverty line can get government assistance, and those who live within the high income bracket can afford the high diabetes costs. However, the 70 to 80% of middle income bracket persons receive zero government assistance and still struggle with the high costs. However, India has addressed some of these concerns. Innovative Indian pharmaceutical companies have introduced some generic anti-diabetic drugs, which have made them much more affordable. The Ayushman Bharat scheme, under the Niti Aayog program, has planned to set up 150,000 health and wellness centers focusing on non-communicable diseases like diabetes, half of which are already operational. These centers have a goal, if they don't already have this, of having essential medications available. One social determinant of health addressed was education. Many Indian people in India perceive that long-term prescription med use is harmful and often rely on homeopathic and Ayurvedic treatment. These treatments often mask the symptoms of diabetes. In Australia, type 1 diabetes patients have a life expectancy of 70 years or more. They often have subsidized access to medications and equipment, which includes continuous monitoring, insulin, home glucose, and ketone monitoring. Treatment for complications due to diabetes are often subsidized by the government as well. The Australian people have access to multidisciplinary teams who are very skilled and are accessible in person and through telehealth. In Canada, universal health care exists, however, this does not cover prescription medications. Many people have to use private coverage through their employer or pay out of pocket. However, the costs are still significantly less than the United States, at an average of about 1/5 of the cost compared to the US brand name counterpart. Many groups of people do receive government assistance, such as in Ontario. People above 65 or below 25 only have to pay a $5 monthly fee, which covers all their monthly drug cost prescription expenses. Also, those with low socioeconomic status and disabilities pay essentially no out-of-pocket costs. In the United States, as we all know, the high cost is due to the lack of cost regulations. Those who are insured versus uninsured pay vastly different amounts for the same medication. Providers also run into issues due to complex paperwork, such as prior authorizations, in order to be approved by insurance companies. In both the United States and Canada, differential access is based on social determinants of health, such as geography, ethnicity, and socioeconomic status. The social determinants of health highlighted within the Global Diabetes Compact include healthcare inequities, which strive to improve the disparity of essential medications and healthcare accessibility, as well as socioeconomic status, which strives to improve the affordability of essential medications to those who are low income, as well as improve health literacy in those who are low education. 80% of those who have diabetes live within developing countries. However, these countries only comprise 1% of global diabetes expenditure. Finally, food environment is another social determinant of health highlighted. Having healthy food options while decreasing food insecurity will help to improve global diabetes outcomes. The World Health Organization, through the Global Diabetes Compact, has addressed that diabetes in many cases is a preventable disease, and in all cases, a treatable disease. Any deaths resulting from diabetes, therefore, are preventable. By directly acknowledging those who impact diabetes care, improvements can be made to diabetes outcomes worldwide. They highlight that the key is through coming together while focusing on having the goal to improve human life. If you have any questions, please email me at the email below, and my references are listed in the next slides. Thank you.